Thank you for joining us for the third and final webinar in our three-part Cancer Care series. My name is Audrey Wetzel. I am a member of the Patients, Families, and Consumers Cabinet of the Patient-Centered Primary Care Collaborative. In support of the American Cancer Society, the PCPCC Center for Patients, Families, and Consumers has developed a 3 fact sheets checklist to enable patients with cancer to better communicate with their primary care and oncology teams during their initial diagnosis, during treatment, and as a survivor of cancer. Today's webinar, Working with Care Teams After Treatment, will feature Dr. Larissa Nekledov, who is a general internist and associate professor at Harvard Medical School. You can access the checklist from the PCPCC's website at pcpcc.org. In addition, the recording and slides for today's webinar will be archived on the PCPCC's website starting tomorrow. You can also find all of the PCPCC's archived webinars under the Resources tab along the top of our website. You're able to submit questions during the course of today's webinar by using the drop-down box on your screen that's in the control panel that you've accessed in order to connect with today's webinar. You'll be asking questions of the speaker since there will be no live feed during today's presentation, and we'll go over those questions during the last 15 or 20 minutes of today's session. I'm going to introduce our speaker for this afternoon is Dr. Larissa Nekledov. She's a general internist with Harvard Vanguard Medical Associates and associate professor in the Department of Population Medicine at Harvard Medical School. Dr. Nekledov is particularly interested in improving the care of cancer survivors and the interplay between primary and oncology care. She has led numerous national efforts to educate primary care providers and caring for patients across the continuum of cancer care. And she's developed her own website offering cancer survivorship resources to primary care providers. And you can access her website by going to www.cancersurvivorshipprimarycare.org. Again, that information is www.cancersurvivorshipprimarycare.org. I will now turn it over to today's speaker and begin today's presentation. Dr. Nekledov.
Thank you very much, and thank you very much for inviting me to give this presentation today. I have learned quite a bit about PCPCC and have been quite impressed by the content that is provided online by organization. As mentioned, I'm the third in the line of presentations focusing on the role of primary care providers in cancer care. The first one focused on the diagnosis phase, the second on the treatment phase, and today I will discuss the survivorship phase. Okay. As many of us are aware, primary care providers are involved to a varied degree with patients across the cancer care continuum, beginning with prevention and screening and proceeding all the way through the end-of-life care. But we also know that these stages are not static and independent of one another. There are transitions that occur as patients move from one phase to another, and certainly the path may not be direct. First, I'd like to introduce you to a cancer survivor, but noting that cancer survivors are quite diverse, and I will explain this later. In this case, it's a patient who's a 7-year-old woman who was diagnosed with breast cancer in 2004 and underwent treatment with mastectomy, but also with adjuvant chemotherapy and radiation. She then went on to receive tamoxifen and then transitioned to an aromatase inhibitor. From the standpoint of her treatment, she has had neuropathy complications as well as joint aches. She's actively engaged in surveillance, followed by a number of providers in this care. She's up to date with other age-related screening and prevention. She does have numerous comorbid medical conditions, many of those occurring prior to her diagnosis and treatment, and is managed by other specialists. From a psychosocial perspective, she is retired, quite active, but worried about cancer all the time. Now let me give you a bit of an overview of cancer survivorship nationwide. Many listening may be aware that over the last 4 decades, the number of cancer survivors has grown, and the most recent numbers suggest that there are over 13 million cancer survivors in the United States. The American Cancer Society has now projected that this number will actually increase to 18 million by 2020. Many of the cancer survivors are living longer following their diagnosis, and as you can see on this figure, most cancer survivors have lived beyond 10 years following their diagnosis. Longer-term survival is great news, but this also means that patients have ongoing needs after their treatment is completed. And what is striking about this figure is that most cancer survivors are older than 65, and the rates of cancer survivors among the elderly is really expected to grow substantially over the next several decades. So this basically means that as more cancer survivors live into older ages, they will have comorbidities related to age that will require management. So putting this together, what does this really mean? Really, cancer survivorship care is not just about cancer. There are multiple aspects of care that we have to provide for the cancer survivors. Of course, we need to focus on cancer-related medical care, such as surveillance or monitoring for recurrences, looking at complications of treatment and managing them, and then also focusing on the cancer-specific related cancer screening. Then we need to focus, of course, on their non-cancer related medical care, such as disease prevention and vaccination, chronic care, such as management for their diabetes or coronary artery disease, and then focusing on unrelated cancer screening. And lastly, we really need to pay attention to the psychosocial issues, including quality of life, financial implications, and also the implications of patients' cancer on the family and genetic risk. And among all of these aspects of care, we need to look at coordination of care and make sure that the care is not duplicated and is really the most quality that can be provided. And as a primary care provider, I certainly grapple with the challenge of providing this care to patients. And really, I think the main focus is that cancer survivorship care, again, going back to my original statement, that it's really not just about cancer, but it's really care for the cancer survivor. So where do cancer survivors get their care? Most are really cared for in non-academic settings, which might be an oncologist only who's providing their care, an oncologist plus a primary care clinician, a primary care clinician only, multiple oncology specialists with a plus or minus PCP, or really no care at all. And what's important to note is that in the real world, cancer survivors are mostly seen in primary care settings. In a study by Snyder and colleagues, the researchers looked at SEER Medicare data to look at patterns of care for cancer survivors. And what they basically showed is that from the time of diagnosis through the first 5 years of care, primary care providers play an important role in caring for cancer survivors. And the longer that it takes from the time of diagnosis, the care of the primary care by the primary care provider actually continues to increase, and there's less of a role for the oncologist. And so this was in the colorectal cancer population, and the same thing was really seen in the breast cancer population as well. So one might ask, why not provide care to cancer survivors in oncology settings only? Well, certainly oncologists get to know their patients and form a bond with them during time of crisis. Oncologists expect to care for cancer survivors, particularly with respect to surveillance. And oncologists do a better job in having patients participate in recommended cancer surveillance. But really, oncologists are not trained to provide general medical care and manage comorbidities in the growing numbers of patients. In this figure, published by AHRQ just this year, you can see that about 50% of those aged 45 to 64 had at least one comorbid medical condition, and 80% of those aged 65 and older have such a condition. The number of patients with comorbid medical conditions has increased over the past 10 years, where now 7 out of 10 deaths are due to chronic diseases. And as 1 in every adult is obese, the rates of comorbid medical conditions will continue to increase in the years to come. And what's important to note is that there is evolving data suggesting that cancer patients with comorbid medical conditions, particularly diabetes, have worse prognosis than those who do not. Another challenge for oncologists to provide care for a growing population of survivors is workforce. In a recent analysis of oncologist supply and demand, it was shown that the demand for oncologists around 2010 was going to supersede that of their supply. So what's notable here is we are now 3 years out, and the discrepancy between the supply and demand will only continue to widen in the years to come. So let's look at the prospects of cancer survivorship care in primary care settings. Primary care providers are indeed trained to provide comprehensive care to patients with chronic diseases. Prior studies have shown that more PCPs in a particular geographic environment result in better health outcomes. Primary care providers are willing to care for cancer survivors, and they focus on general medical screening and prevention. And at least in breast cancer, there have been no differences found between mortality among patients followed by primary care versus oncologists. But there are certainly challenges for primary care-based survivorship care. There is often inadequate information about the previous cancer or its treatment. Some patients do not know the specifics of the types of cancer that they had, and certainly not the names and doses of the chemotherapy agents that they may have had. Some cancers are rarely encountered in primary care settings, so primary care providers really cannot have enough expertise to take care of those patients. And this is particularly the case for adult survivors of childhood cancer. There's lack of knowledge and confidence about survivorship care among primary care providers. And in a recent paper, I showed that primary care providers' awareness of late effects of chemotherapy agents is really lacking in primary care. Patients lack confidence in primary care knowledge as well. And of course, there are competing demands on our time as primary care providers because in addition to providing care for cancer survivors, we need to focus on lots of other medical conditions and comorbid medical conditions. And what's shown on this slide is similarly to the decreasing supply of oncology providers, there's also a shortage of primary care providers. As you can see on the left-hand side of this figure, the gap in the demand and supply is shown in the yellow. And it shows that there's already a shortage of about 9,000 primary care providers nationwide. But as the years go on, the shortage is really expected to drastically increase. The other aspect that I mentioned is psychosocial care, and patients have expressed ongoing need for emotional support. They look to both their primary care providers and their oncologists to provide them with psychosocial support, but data suggests that neither adequately address these needs. Patients have reported confidence in PCP caring for their psychosocial well-being. And in one study of 300 breast cancer survivors, most were confident in PCPs providing their general care, psychosocial support, and health promotion. But as I mentioned earlier, they were less confident about PCP's knowledge of cancer follow-up, late effects of cancer therapy, and treating symptoms related to cancer. I'm going to share with you a few quotes from a recent qualitative study that was published asking for patient preferences in oncology and primary care follow-up. So first focusing on oncologists, and I'll just read the quotes out to you that you can follow along. If there's anything, considering anything in reference to cancer treatment, I would see my oncologist for it, just because that's their specialty. I'd rather see the oncologist, someone that is familiar, who does it every day. I just wouldn't think that a primary or my gynecologist would be as knowledgeable. Another quote, you got to have an oncologist. I would advise anyone not to go to a family doctor or a general practitioner. You got to be an oncologist. You know, I'm a firm believer. My head hurts, I'm going to the head doctor. My foot hurts, I'm going to the foot doctor. And then some other opinions from others. I mean, as far as being a liaison between me and that oncologist or me and the surgeon, that's what my primary care is for, in my opinion. That's how I used him to be my go-between, to explain the things in the files that I didn't understand. Maybe OBGYN could be involved in follow-up. When I go there yearly for the clinical exam, they'll usually question about the breast cancer and stuff like that. And lastly, knowing my history is okay too, but they should be involved together because primary care knows more about me other than the cancer. So how about shared care, where a primary care provider and the oncologist together participate in the care of the cancer survivor? All really seem to like this approach. The patients want their oncologists and PCPs involved in surveillance for cancer recurrence and other cancer screening. Oncologists expect a significant role in surveillance, but also share in the screening for other cancers, and the general prevention with primary care providers. Primary care providers prefer to focus on screening, general prevention, and some in surveillance. And this type of model appears to improve all indices of care for cancer survivors. But of course, there are challenges to shared care. There's often lack of clear communication between cancer specialists and the primary care clinician. There's lack of infrastructure support within the healthcare systems to share and transfer records, focusing on information technology and electronic medical records. In other disease states, there's actually been inconclusive evidence for the benefits of shared care. One of the issues is that there's really no systematic way to define and delineate care and responsibilities. In other words, who is going to do what and where and when. But we need to balance too little care and too much care, or duplication of care. And of course, the big question is there an end to shared care? In a study that was published a few years ago, you can see on this figure that among cancer survivors who have lived 6 years or more following their cancer diagnosis, they continue to have a lot of visits to not only primary care, but also to other providers. As you can see, starting with the bottom, these are visits to the primary care provider in the dark blue, then going up to the medical specialists who are not in cancer care, then going up to the third level are other providers, followed by cancer-related providers, and the last one being cancer specialists. So if you add these numbers up, you can see that even 6 years after, 6 to 10 years after their diagnosis, cancer survivors are seen by about 10 providers every year. And I wanted to point you to a recent video that was posted by AHRQ highlighting the multiple chronic conditions and what this means to a patient. As you can see here, she has arthritis, hypertension, and depression, but you can put a whole bunch of other chronic medical conditions on this slide. And I think that once these slides are posted, you should be able to follow the link provided, which actually appears that it's not included in the slide. But we will provide a link to this. So clearly there are challenges in coordination and communication across the cancer spectrum. As illustrated on this figure, along the path of cancer detection through survivorship, there are numerous providers, ancillary staff, and of course the patient, his or her family, and community. So going back to the other patient that I presented with breast cancer who also has numerous comorbid medical conditions, you can almost guess that there is potential for lots of interactions. And indeed, you know what, all right. And indeed, you can see that this patient must interact with lots of physicians, their nurses, and staff. The primary care provider is also challenged by keeping up with the care that this patient is receiving from each of these providers. So naturally, a question must arise, are there any solutions to this? How does one successfully care for a cancer survivor, particularly one who has comorbid medical conditions? In the mid-2000s, the Institute of Medicine convened a panel to look at what happens as patients transition from active cancer treatment to survivorship. And they published their findings and their recommendations in a report in 2006. There were a number of recommendations, but one of them I'll read to you, in that patients completing primary treatment should be provided with a comprehensive care summary and follow-up plan that is clearly and effectively explained. This survivorship care plan should be written by the principal provider who coordinated oncology treatment. This service should be reimbursed by third-party payers of healthcare. And just note in this that there's no mention of that this should also include how the treatment involves and impacts on comorbid medical condition management. So it's been about 10 years since the report came out, a little bit less than that. And how is this going so far? Well, it's still a work in progress. There are certainly challenges in implementation, even among Livestrong survivorship centers and NCI-designated cancer centers. Modifications to the survivorship care plan requirements are currently being developed by the American Society of Clinical Oncology. But what's important to note is that survivorship care plans will soon be a requirement by the Commission on Cancer Accreditation. But one thing that really needs to be highlighted in all of this is that a survivorship care plan does not equal survivorship care planning. So I wanted to share with you the newest findings from the Institute of Medicine. I recently had the privilege of serving on another IOM panel focusing on cancer care. In this one, a panel included a group of clinicians, researchers, policymakers, and patients. And we were charged with the task of identifying problem areas in cancer care and provide recommendations for improvement. I wanted to share with you some of the recommendations made by the committee that are particularly relevant to the topic of patient-centered care of patients with cancer. Upon doing our review, we concluded that there is a crisis in the cancer care delivery, and that cancer care is often not as patient-centered, accessible, coordinated, or evidence-based as it could be. We then outlined 10 recommendations. I think that each one of the recommendations is relevant to PCPCC and the audience that is listening to this webinar, but I'm going to review for you and really focus on the top 4, which I think are probably most relevant. And I will work through these. The first one really aimed at engaged patients. And the goal here was that the cancer care team should provide patients and their families with understandable information on cancer prognosis, treatment benefits and harms, palliative care, psychosocial support, and estimates of the total and out-of-pocket costs of cancer care. The committee embraced the framework that patient-centered care leads to improved communication and thereby to improved health outcomes. To achieve this goal, the committee recommended that the cancer care team communicate and personalize this information for their patients at key decision points along the continuum of cancer care using decision aids when available. And that they also collaborate with their patients to develop a care plan that reflects their patients' needs, values, and preferences, and considers palliative care needs and psychosocial support across the cancer care continuum. There are a number of elements that the committee recommended that should be included in the care plan, and these are listed on this slide. Specifically, patient information, diagnosis, prognosis, treatment goals, initial plan for treatment, expected response to treatment, treatment benefits and harms, information on the quality of life, who is responsible for care, advanced care plans, cost of care treatment, a plan for addressing psychosocial health and survivorship plan. Lots and lots of information to be included. How feasible this will be in the long term is to be determined, but we wanted to be sure that we provide recommendations for what we felt was the most quality care. Other recommendations pertaining to this goal also aimed at CMS, Medicare, and other payers, as well as funding institutes such as the National Cancer Institute, PCORI, patient advocacy organizations, professional organizations, and other stakeholders. And of particular importance to this group is the recommendation that professional educational programs for members of the cancer care team provide comprehensive and formal training in communication. The second goal also aims at engaged patients, but specifically focusing on those with advanced cancer, advising that the cancer care team provide patients with an end-of-life care that is consistent with their needs, values, and preferences. Again, we recommended that professional educational programs for members of the cancer care team provide comprehensive and formal training in end-of-life communication, that the cancer team should revisit and implement their patients' advanced care plans and provide palliative care, psychosocial support, and timely referral to hospice for end-of-life care. And again, we targeted CMS in this recommendation. The third goal aimed at making sure that we have an adequately staffed, trained, and coordinated workforce. Specifically, that members of the cancer care team coordinate with each other and also with the primary or geriatrics and specialist care teams to implement patient care plans and deliver comprehensive, efficient, and patient-centered care. The committee clearly recognized the important role that primary care providers play in the role of cancer patients. As you can see here, the primary care providers on the right side, the cancer care team, and other specialists together surrounding the patients and having patient-centered interactions. We also recognize that the cancer team includes more than physicians. And as you can see on this figure, it includes nurses, pharmacists, physician's assistants, rehabilitation clinicians, palliative care providers, and providers of psychosocial care. For this specific goal, we focused on academic institutions and professional societies, asking them to develop interprofessional educational programs to train the workforce in team-based care and promote coordination with primary geriatrics and specialist care teams. There were other recommendations that targeted the federal and state legislative bodies and the National Workforce Commission, which I will not highlight today. And the fourth goal, again, focusing on adequately staffed, trained, and coordinated workforce, really emphasized that all individuals caring for cancer patients have appropriate core competencies. And with that in mind, we recommended that professional organizations representing clinicians who care for patients with cancer define cancer core competencies for their membership. And cancer care delivery organizations should require that the members of the cancer care team have the necessary competencies to deliver high-quality cancer care and demonstrate that through training, certification, and credentials. And lastly, that organizations responsible for accreditation, certification, and training of non-oncology clinicians provide and promote development of relevant core competencies across the cancer care continuum. In other words, while primary care providers may not need to know the specifics of cancer treatment, there are certain core competencies, certain knowledge, skills that they need to have in order to provide quality care for cancer patients. The next goals focused on research, both in the traditional sense and also in developing a learning healthcare system, and also on the IT system for care and developing national quality reporting system for cancer care. Lastly, the committee recognized the need to reduce disparities in cancer care and improve the affordability of cancer care, both by emphasizing evidence-based care and eliminating waste. So in conclusion, from the IOM, all participants and stakeholders must reevaluate their current roles and responsibilities in cancer care and work together to develop a higher quality cancer care delivery system. And by working toward this shared goal, the cancer care community can improve the quality of life and outcomes for people facing a cancer diagnosis. You may access the full reports and watch a video that was released summarizing some of the findings by following this link, and it will be provided for you. So again, to summarize, it is important to highlight that in cancer survivorship care, or caring for the cancer survivor, we're really aiming to provide comprehensive care to cancer survivors in a coordinated and patient-centered way. There are, of course, hurdles in caring for cancer survivors, as I alluded to earlier in the presentation. Cancer survivors are diverse. Some cancers are rarely seen in primary care settings, so we can't have enough expertise. There is inadequate information about the previous cancer and its treatment, lack of knowledge and confidence about survivorship care, patient lack of confidence in primary care knowledge, competing demands on primary care time, numerous specialists leading to gaps in communication and coordination, and shortage. And there are global challenges in survivorship care. There is lack of clear evidence-based guidelines on proper management and limited knowledge of evolving management of comorbidities. While some guidelines do exist, these are very limited and not often based on clear evidence. And there is lack of effective management of information and transfer of information between providers needed for coordination of care. Electronic medical records may be helpful in this regard, but probably more needs to be done. To help facilitate evidence-based care, guidelines have and are being developed by national organizations, including the Children's Oncology Group, focusing on adult survivors of childhood cancer, NCCN, and ASCO, focusing primarily on adult survivors of adult cancers. There is more and more work that is being done in the area of survivorship care planning. In this paper that I recently published with a hospitalist, really draws analogies between hospital discharge summaries and survivorship care plans, and points to ways that we can learn from years of hospital discharge summaries and hello? And draws two analogies between hospital discharge summaries and survivorship care plans. And there are educational efforts that are being targeted at oncology and primary care providers. This is from Up to Date, which is an online resource that is used by over 70,000 clinicians worldwide. There is now a section focusing on survivorship and is really meant to be friendly not only to oncology providers, but also to primary care providers. And lastly, as mentioned earlier in the presentation, in the introduction, I would like to share with you a website that I created with the goal of providing a one-step repository for primary care providers to quickly access resources for cancer survivorship-related medical information and clinical guidance. So there is an abbreviated URL that is presented here. And that concludes the formal presentation, and I'd love to take some time to answer questions.
All right. Thank you, Dr. Nikladov. I would now like to open up for Q&A and just remind everyone that in the question box in the control panel, in your control panel, please feel free to ask your questions there. If we don't have time within the next 20 minutes to get to everyone's questions, we will forward those over to Dr. Nikladov for her review and hopefully be able to respond to you individually. But so we'll give everyone a minute or two. But we do have one question, Dr. Nikladov, that is, should case managers for cancer patients be aligned in primary care offices or in the specialty office?
Yeah, that's a very good question. I think that certainly case managers should be available and closely working together in the oncology offices. I think it would be very helpful for primary care providers to at least have a listing or available resources where they can tap into the case managers who are really more educated and can provide care to cancer survivors. I think even though there are growing numbers of cancer survivors that are seen in primary care settings, I think just thinking in terms of cost and convincing primary care organizations to have such personnel within their settings, I think that might be difficult to sell.
All right, great question. Are there any other questions? One of the questions I'd like to ask Dr. Nikladov, I noticed that there were a couple of areas where you talked about the technology solutions that are currently being introduced into helping drive education at the primary care setting. Is there any work being done around creating some sort of templates that these practices might want to or easily be able to adopt as best practices in terms of how they respond to patients?
Mm-hmm. Yeah, so certainly, there's lots that's being developed in the IT world. I think as far as education is concerned, certainly webinar programs and online educational programs are being developed. As far as templates are concerned, there are a number of templates that are available for practices to put together a survivorship care plan, populating it with sort of the basic information that would be helpful to both the patients and the primary care providers. And such templates are available on the ASCO website, so that's the American Society of Clinical Oncology website, There's also an organization called Journey Forward. There are some that have been developed by the Livestrong Foundation. And just to point out, if you go to the website that I created, the PCP.org, if you follow one of the tabs for survivorship care plans, it will get you to a list of links to the current templates that are available for survivorship care plans.
All right, thank you. All right, we have another question. Do you feel it is beneficial to have mental health providers in the oncology specialist office for survivorship needs, such as anxiety?
Yeah. So, I mean, I think absolutely. I think that within oncology settings, I think it's very important to have access to mental health providers. And even, early in the survivorship phase, the number one concern of cancer survivors is risk of recurrence. And I think having somebody available at the oncology setting, I think, would be, very helpful. I think they can also, provide some psychosocial support, but also determine whether the patient needs additional intervention, such as perhaps medication for anxiety or medication for depression. And then this would be an opportunity for them to refer the patient back to the primary care provider, who often does have the skill and the knowledge to provide pharmacological treatment to these patients. Patients may not necessarily want to go outside and actually seek a psychiatrist. There's still a lot of issues related to that, but I think sending the patient, evaluating the patient, and then referring them back to the primary care provider for further management, I think is certainly something that would be helpful for the mental health providers in oncology settings to provide.
All right, great, thanks. For cancer survivors, when is the most intensive care coordination case management needed by primary care, and are there time frames or contact suggestions for reaching out to the oncology patient?
Yeah, so that's a very good question. I think, so clearly one of the main time frames is at the tail end of treatment, of active treatment. So the patient is expected to finish their chemotherapy or their radiation therapy let's say, in the next month or so. I think that would be a very good opportunity to really intervene and make sure that the patient, the oncology providers, and the primary care provider is on board for what needs to happen with the patient, what kind of care, what kind of follow-up will need to happen for that particular patient. But having said that, I think that it's also important to keep the primary care provider in the loop to the greatest extent possible, even during active treatment. Often patients who are followed in oncology settings during cancer treatment sort of stop paying attention to their other healthcare needs, including, for example, diabetes or high blood pressure. And I think that it's important that even during active treatment, there is that communication and coordination between the oncology team and the primary care team that continues to occur.
Okay. We have a two-part question from Wendy Abgar. The first is, when a patient is on hospice, should hospice also focus on the comorbidities or just the cancer? And also, is more being done to use alternative treatments as opposed to medications?
Okay. So I think as far as hospice care, I mean, I think that, hospice care, palliative care, I mean, sort of going along the lines of the Institute of Medicine recommendations that I reviewed, it's really important that the entire team look at the overall comprehensive approach to this patient and really determine, what are the aspects that are most critical for us to manage. And really, if the long-term prognosis is very poor, then really we need to focus on pain control, for example, and probably pay less attention to anything else. It doesn't make sense to manage, other comorbid medical conditions if the overall goal is to control pain. So I think, again, we really need to look at the entire patient, talk to the family members, and have the entire team make a decision on what's within the best interest of the patient. And I think with respect to your other question, it probably goes outside the scope of my presentation. I think that, there are probably providers who focus on the sort of the traditional Western medicine treatment approaches and probably alternative as well.
Okay. The next question is, for cancer survivors, when is the most intensive care coordination case management needed by primary care? And are there, oh, I think we've done this one.
Yeah.
I'm sorry. I think that's all the questions we have. Again, I'd like to remind everyone that's on the call is that please feel free to log in to the PCPCC's website. These slides will be made available to you tomorrow, starting tomorrow. They'll be posted. Also, Dr. Nekledov's website information is also going to be there along with those slides. Thank you once again for taking time out today and participating in today's webinar. Please feel free to visit the PCPCC's website. It's a great resource for many questions as it relates to patient-centered care. And once again, thank you, Dr. Nekledov, for helping us with getting more and more information about how do we respond to the treatment of cancer and the integration of cancer care into primary care.
Thank you.
You're welcome.